Michigan. And today I'm going to talk about a case example where we implemented antibiotic de-escalation specifically in our AML patients with fever and neutropenia. In this presentation this afternoon, I'm going to build on Dr. Liu's presentation where she's already presented on the guidelines and some of the primary literature for de-escalation in fever and neutropenia. Then I'm going to talk a little bit more about how to implement a guideline in your hospital, what were the challenges that we had to face, and hopefully give you a few clinical pearls for getting the guideline developed, getting it implemented. And then number two, today I'm going to go over our de-escalation guideline at the University of Michigan, and then also present some data, kind of pre-post guideline implementation related to antibiotic prescribing and patient outcomes. I think one of the most important things you need to think about when you're building your guideline and making the case for doing de-escalation in neutropenic patients is how you're going to sell this to oncologists. You can't go to them and say, I think we should do this because it's going to reduce cost. Or you can't do it and say, I want to reduce our antibiotic utilization numbers. I really think it's got to be focused on patient outcomes and development of resistance and other complications. And so I'm going to go over a few slides here and talk about building the case for de-escalation. And at our hospital, when we were developing this guideline in 2015 and 2016, we saw our very first CRE infection in oncology patients in 2015. And that was kind of a little bit of a wake-up call for oncologists, and they were very worried about this being the tip of the iceberg, potentially having more CRE infections in their patients. Also in our institution, about a third of all VRE bacteremias are in our onc patients. And then lastly, when you look at our C. diff rates, this table down here, this figure down here, is all of our services at our hospital. And the bar that's highlighted red is our service that takes care of leukemic patients. And you can see out of all the services in the hospital, they're the fifth highest C. diff rate as far as cases per 10,000 patient days. So again, I think kind of highlighting these type of things when you're developing your guideline and trying to provide reasons for implementing the guideline is crucial. You know, you want to reduce CRE, you want to control VRE, and you certainly don't want to promote C. diff if you don't have to. At our institution, we put together an antibiogram that was very specific to oncology patients with fever and neutropenia. Depending on which cancer, type of cancer the patient's presenting with, we will treat those patients with either piperacillin and tazobactam or cefepime if they develop fever and neutropenia. And not surprisingly, neither one of these agents are going to cover every single gram-negative pathogen that we have in fever and neutropenia patients. You can see from our data here, piperacillin and tazobactam worked 86% of the time against gram-negatives, and cefepime had activity against almost 94% of pathogens. So we took our antibiogram data one step further, and we asked ourselves, what are the risk factors associated with somebody getting a gram-negative infection with a piperacillin tazobactam resistant organism? Piperacillin tazobactam is currently our go-to drug for AML patients that develop fever and neutropenia. And we conducted a little study, and we ended up finding 6 factors on univariate analysis that were associated with development of a piperacillin tazobactam resistant gram-negative infection. However, when you look at multivariate analysis on the right side of this table, highlighted at the bottom, there was really one factor that ended up being statistically significant for developing a zoonosis-resistant infection, and that was if patients received antibiotic therapy for more than 14 days sometime in the previous 90 days. And you see the odds ratio, you were about sixfold more likely to have a zoonosis-resistant organism if you've had extensive antibiotic therapy in the last 90 days. And if you think about it, a lot of our AML patients, particularly our relapse refractory AML patients, or I guess any AML patient, is pretty likely to have extended courses of antibiotic therapy, which place them at a higher risk for having a zoonosis-resistant gram-negative infection. Another reason to consider de-escalation in fever neutropenia patients is the impact of intestinal biodiversity on mortality when patients ultimately end up needing a bone marrow transplant a bone marrow transplant. And this is a nice study that was published in Blood in 2014 that looked at the intestinal biodiversity and classified it as low, intermediate, or high. And as you can see, if you have a low diversity of your normal flora, then your mortality rate is significantly higher than if you had intermediate diversity or high diversity. Now, if we take biodiversity a step further, this is a nice analysis that again categorizes patients into high diversity, intermediate diversity, and low diversity. On the left side there, you can see the three different groupings. And sorry this is a little bit hard to read, but I kind of just want to point out the fact that when you look at not only death, but also other outcomes such as GVHD, infection, relapse rates, at the top of this graph, when you look at the high diversity group, they have relatively lower incidence of having GVHD, relapse, infection, things like that. But as you move down this figure to the intermediate and low diversity, the incidence of these complications becomes much higher. Now, in all fairness, I have no idea if I use less antibiotics, does that mean that they end up ultimately having a higher diversity of normal flora and less complications? I think those studies are still to be determined, but this definitely raises a red flag in that if these AML patients end up needing a bone marrow transplant, then diversity seems to matter when it comes to not only mortality, but also other complications, infections, relapse rates, things like that we see in bone marrow transplant patients. So this slide here is actually a little flow diagram of our AML de-escalation guideline, and this sits within a larger document that talks about treating fever neutropenia, both initial treatment and de-escalation of therapy. And so I'm going to just walk through this really quick, but essentially, just like you would anybody else, if somebody presents with fever and AML, we start broad-spectrum IV antibiotics. There's no question most of these people are at high risk, so they need IV antibiotic therapy up front. We obtain cultures, we perform appropriate workup for infections, we get imaging, we do physical exam, things like that. So everybody gets all the standard upfront therapy on day one. And then on day 5, we ask teams to reevaluate the patient. And we put them into kind of 3 different buckets. We put them into low suspicion of bacterial infection there on the left side. And our definition of this is basically there's no cultures that have turned positive. All the physical exam, you can't find any foci of infection, and there's no radiographic studies that suggest there's infection. So there's no CT for that's suggestive of pneumonia. There's no physical exam that's suggestive of pneumonia. These people literally just had a fever, and you couldn't find anything that any source of infection. So these are low suspicion for bacterial infection. And then the middle category here is suspected bacterial infection. So this one, there's something on imaging or physical exam which suggests infection, but the cultures are negative. And then the last bucket we put people into was documented infection. And these people had a positive culture plus either positive physical exam consistent with infection or imaging consistent with infection. Now, when you go down the left side of this document, the low suspicion for bacterial infection, so when we evaluate these people at day 5, and we do not do this before day 5, I know other studies have done it at day 3 or different time points, but we start evaluating at day 5. And we put them into these buckets, and we ask basically, is the patient clinically stable and afebrile for at least 48 hours? And then in the low suspicion group, if that's the case, then we ask them to de-escalate therapy. And by de-escalation, we mean going to prophylaxis, usually with a quinolone for refractory relapse AML patients, or if it's a newly diagnosed AML patient, we actually discontinue all antibiotic therapy and just do a watch and wait approach at that point.
Do you like medicine fellowship? It's not medicine, fellowship fellowship.
Moving on to the middle category here of suspected bacterial infection. Again, these patients have negative cultures, but they do have something on imaging or physical exam suggestive of infection. And so what we want to do for these patients in our guideline is actually ask the question again, are they clinically stable and afebrile for at least 48 hours? If they're not afebrile or they're not hemodynamically stable, then we're going to continue IV anti-pseudomonal therapy. But if they are afebrile and they're clinically stable, then we actually tailor therapy at this point and treat their suspected source of infection. I'll show you the next page of this guideline in just a second here, but we talk about treating them for the right duration. After we treat them for the right duration, then at that time, we switch them back to their prophylaxis regimen. Again, a quinolone if they're refractory relapse, or no antibiotics for our newly diagnosed AML patients. So for patients with suspected bacterial infection, this is a really rough guideline, rough chart for how long these patients should stay on targeted therapy for their infection. So in the suspected bacterial infection category, that middle column, if somebody had pneumonia, they had a positive chest CT or chest X-ray that suggested pneumonia, but their cultures are negative, this guideline recommends 7 to 14 days of therapy. So we would treat them, probably if their cultures were negative, we would treat them with Zosyn or cefepime would be our first line agents. We try to do 7 days if they responded really rapidly, doing great. We treat them a little longer if they've taken a little longer to respond to therapy. So we treat them somewhere in the 7 to 14 days. And then at that time, we say that's enough therapy and we step them down to prophylaxis if it's indicated and stop IV anti-pseudomonals at that point. All right, moving over to the far right column, these are patients with documented bacterial infection. They have positive cultures. They have something on physical exam or imaging suggestive of infection. And so we definitely want to treat these patients. So we give them therapy, but we are targeting their therapy to the pathogen. So if it's a gram-positive pathogen or a fungal pathogen like Candida, we will start their therapy. Let's just say it's a candidemia. A lot of times we'll start mycofungin for candidemia, and we will actually discontinue or switch these patients to prophylaxis with levofloxacin. So we're stopping their IV anti-pseudomonal if we know that they have a pathogen that's not gram negative. And then, similar to the previous column, suspected bacterial infection, we refer to the chart on the back. We give them the right duration of therapy, and then after that duration is up, we're switching them to prophylaxis at that point. And the last part of this flow diagram is probably one of the most important, is that we just can't de-escalate these patients and walk away. These people are neutropenic. They're profoundly neutropenic for a longer duration, and they are going to be at risk for developing infections. And we see, historically, these people will develop infections even if they're on Zosyn or Cefpime or meropenem, and they'll develop infections when we take them off of anti-pseudomonals as well. So we need to keep a really close eye on these patients. We need to monitor their fevers, at least daily. And we need to be able to allow teams to restart IV anti-pseudomonal therapy if there is any suspicion of infection.
In 600 meters, keep right.
So we ultimately ended up implementing our guideline in January of 2017, and then we did a pre-post study, and we ultimately evaluated 163 people who were admitted with AML, and ended up including 93 patients in our study who developed fever and neutropenia, 40 patients in the control group, and 53 patients in the intervention group. This slide shows a breakdown of the different demographics in the historic group and the intervention group. And as you can see, for the most part, they're pretty evenly distributed. Age is similar, gender is similar. We had a little bit higher number of patients in the intervention group had refractory or relapse AML. It was 32% versus 17.5% in the historic group. Most patients, 85 to 90% of people in both groups, received either 7+3 or flag therapy. Almost all patients had a central line at the time of their fever neutropenia. Their duration of fever wasn't really that different between groups. It was a median of 4 days in the historic group, 3 days in the intervention group, similar interquartile ranges. And then you look at the breakdown of our classification of infection. In the historic group, 55% of patients had a low suspicion for infection in the historic group, compared to 52% in the intervention group. Very small number of patients had suspected infections in either group. And then 30% of patients in the historic group had a documented infection, and 41% patients had a documented infection in the intervention group. When we looked at the antibiotic prescribing data following the guideline implementation, we looked at two different metrics related to prescribing. The first one was how many patients had de-escalation off of anti-pseudomonals. And you can see in the historic group, only 7.5% of patients ended up having a de-escalation performed. After we went live with this guideline, 71.7% of patients had de-escalation performed. And then on the right side, when you look at the days of therapy per patient, patients received an average of 25 days of an IV anti-pseudomonal in the historic group, which dropped by about 45% down to 14 days of antibiotic therapy in the intervention group. And both those were statistically significant. So just as important as looking at antibiotic prescribing data, we need to make sure that even though we were giving these people less antibiotics, less broad-spectrum IV anti-pseudomonal antibiotics, that we weren't harming patients. And one of the key primary endpoints that we've looked at was, did patients develop a suspected or documented infection after de-escalation? So when we de-escalated them in the intervention group, 34% of patients ended up needing antibiotic therapy for a suspected infection after we de-escalated them. In the historic group, how we counted this endpoint was we looked at basically when the patient became hemodynamically stable and afebrile from day 5 and afterwards, even though they were continuing on IV Zosyn or cefepime, did they require a change in antibiotic therapy based off a new suspected infection? Either they developed fevers, they had a new culture, something happened which either caused them to escalate their beta-lactam or add on an aminoglycoside. And you can see in the historic group, this happened 45% of the time. When we look at all-cause mortality, 6 patients expired in each group, which was not statistically different. And the median length of stay was similar between groups. It was 29 days in the historic group and 27 days in the intervention group. However, one thing that we were pleasantly surprised to see is a significant reduction in the incidence of C. diff infection in the intervention group. In the intervention group, 5.7% of patients developed C. diff, compared to 27.5% in the historic group, which was significant.
We are now open for car service.
So in summary, I hope this example of our de-escalation initiative has helped you in a few different ways. Number one, I hope kind of walking through how to develop an argument for why this is important was helpful. And, I think that when you're developing an argument and you're discussing antibiotic de-escalation with the oncology groups, I really think it has to be on patient safety and the clinical benefits that can be realized when you standardize care and implement a de-escalation guideline. I think that also in summary, our experience suggests that, patients can be safely de-escalated off of anti-pseudomonal therapy while they're neutropenic without having adverse outcomes. And if you look at also Dr. Liu's presentation, she noted a really nice number of studies, growing number of studies, which also show similar findings. And then lastly, from our experience, we were, again, pleasantly surprised to see a reduction in C. difficile infection related to antibiotic de-escalation. So I want to thank everybody for their time. I appreciate you watching this presentation. Please feel free to email me if you have any questions, need any more data, and I'd be happy to help. Thank you.